range. So, can a quality system work? Well, we checked them off. Is there a problem? Yes. If there is a variation, are there dosimetric and clinical effects? Yes. And lastly, we figured out that you can actually measure the performance of a contouring system. So we know that improvements can be made, and that's what these challenges are about. The challenges give us a way of getting that word out. We do have several publications that are coming out. Ben actually has a publication that's going to come out in the Red Journal, and that should be coming in the next month or two, I hope. There's a couple other publications from the group up in Canada at London. They've got some really neat stuff that they're working on, and we'll be seeing that in the next few months. And basically what it comes down to is, we have tools available now. Structure gives us the tools that allow you to put a contouring quality system into place. And right now, we're looking for the clinicians that are out there that want to, put these tools to use. So, given that, I'm going to turn this over now to John Ruskey, who is from Loyola down near Chicago. And John has been working on putting a quality system into place in his department for his dosimetrist, and he's going to tell us basically, how things are going. John, it's all yours.
Great. Thank you, Neil. It's a pleasure to be here today. I'm going to talk a little bit about a clinical quality assurance system that we developed for our dosimetrists here at Loyola. I want to acknowledge my co-authors, Jen Magliari. She's a dosimetrist, and she originally began part of this project for her master's degree and eventually evolved into something a little bigger. Sophie Hernandez, who's a young, eager resident who worked with us on a lot of the contouring, and so obviously that's very important. And I also want to acknowledge our dosimetrists who spent a lot of their free time doing something that they enjoy more than anything else, which is contouring, namely Jen Price, Jenny Stieber, Stacy Alsager, and Christine Dumsdorf. Obviously, if I don't thank them publicly, I will hear about this for the rest of the year. So as many of us remember, 2010 began with a number of articles in the New York Times that were really very damning to radiation therapy in general, pointing out some of the things that can go wrong when radiation is used improperly or when we don't have proper quality assurance checks in place. And because of that, certainly I think as a field we kind of took a black eye on it, but at the same time it also really gave us a chance to pause and step back and say, look at the questions. How do we achieve quality and safety improvement in our field? How do we know that we've improved things? And certainly there were a number of national meetings and seminars sponsored by ASTRO and AAPM. And so certainly I think contouring is one of those things that fits very nicely into this for all the reasons that Neil previously pointed out. So I think as we take sort of a step back, one of the things we want to think about is what is our current approach to quality in radiation therapy? And generally what we have a target, something that we want to be a parameter that we want to be very close to, and we generally have a specification. And as long as whatever our quality measure is within that specification, generally we're quite happy. So this could be, for example, the daily output on the LINAC. If we're within plus or minus 2 or 3%, generally we're quite happy with that. It could be a DVH parameter, could be a mean DVH value. As long as we're within some threshold, generally we're quite happy. But if we look at, other, sort of a more modern approach to quality, it really does something a little bit above and beyond that. Not only does it try to be within some target or very close to a target value, but it also tries to improve upon the process, making that distribution that I showed before, which was actually quite wide, making it very narrow and very close to the target. And so the specification is meant to be something that's kind of, we generally expect to be within that specification, but we also expect to be better than that specification. And that's, again, sort of the modern approach to quality. So there's really two elements for ensuring quality. One is that whatever our process needs to be, it has to produce accurate results, and also minimum variation. And so we can only achieve optimal quality with a process that's on target with minimum variation. And again, you can think of contouring as falling very nicely in there. We want contours that are accurate, and particularly we want contours to be done consistently among groups of individuals who are doing the contouring. So fortunately, in looking at modern quality assurance methods, generally we look at the airline industries or other very high-risk industries, and there's been a number of techniques that have been developed over time. So we don't have to reinvent the wheel. And a number of these were published by Deming and others years ago. So all we need to really do is look back. A lot of the methods for ensuring quality generally focus on methods and benchmarks, execution and data, monitoring and feedback, all based around some key quality indicators. So within radiotherapy, what are the key quality indicators that we'd like to look at? Well, these can include some very basic items, things such as the time from stimulation to the first fraction, planned turnaround time, fractions of cases replanned. Planning parameters, obviously these are DVH parameters, which will be organ dependent. If we have an IGRT, you may want to look at the daily shifts and how these vary among patients. Contouring is something that we'll talk about. And then obviously things with the LINAC in terms of the output, QA, and other QA measures that we have for the LINAC. So I'm going to focus today primarily on abnormal tissues related to contouring. So in establishing a contouring QA program, this is something that we have to kind of look at and say, well, how do we do it? We generally have QA programs for other things in radiotherapy, but for contouring, we really haven't done a whole lot over the years. So first we have to decide, how are we going to establish a gold standard? How reproducible are contours among an individual? So before we even start comparing individual dosimetrists against each other, we really have to look at the dosimetrists against themselves and see how well they can do, how well they can contour, and how consistent these contours can be. The question which Neil brought up, how good does contouring need to be? Do we have to have line-on-line accuracy, or can we afford to be off a little bit for certain structures? And then, as in any quality assurance program, what is the frequency of assessment? How often do we have to assess how we're doing? So this is the flow chart that we devised for our clinic. And to the left here, we have the delineation of the contours. And the way we decided to establish our gold standard was, first of all, we had our radiation oncologist delineate the normal tissues. And then we brought in a radiologist to confirm the contours and make adjustments. And based on the agreement between the two, this became our gold region of interest. In terms of intra-dosimetrist variation, again, something we wanted to assess before we went too far into inter-dosimetrist variation, we had dosimetrists contour the same structures on one set on a patient, and then repeat the same patient a couple weeks later to see how they do. Because obviously, if maybe they had a bad night, or they have a lot of coffee in the morning, there could be some variation, just within their own contours. And then finally, assessment review. We compared the gold ROIs to the dosimetrist contour, allow them to review the metrics, have visual overlays, and finally, in certain cases, depending upon how the dosimetrists do, they may want to review the contours and see if they can improve and repeat the metrics and see what happens when they repeat these contouring. I hear the fire alarms going off in this room, so I may have to duck out if there's actual fire. So hopefully I'll get through this quickly. The clinical contouring improvement program, basically we took 5 disease sites: brain, head and neck, thorax, abdomen, and male pelvis. Again, as we said, we created the gold set of contours, as we discussed. We have 5 dosimetrists. They're all CMD. The average years of experience is about 5. We also had a student who was 9 months into his 12 months training who was included in this study also. The dosimetrist contoured about 32 organs in all. There was no time limit. For the repeat case, they contoured about 1 week later for the pelvic case. So here's a list of the organs that they contoured, and this is listed pretty much from head to pelvis. So you can see, we have the brain, the optic organs, going down to the neck level, the parotids, mandible, the cord, lungs, esophagus, carina, down into the abdomen, the abdominal organs, and then finally into the pelvis.